Good morning. You're very welcome to session 7 and day 2 of the World Sepsis Congress 2021. And this session is about understanding the different faces of sepsis. And I'd like to give a very warm welcome to our international audience here today, and to thank very much our very diverse panel of experts who have very graciously given of their time. I'd like to thank our sponsors, the Global Sepsis Alliance, the lead, Professor Tex Kassoon, Marvin, who has so ably organized these congresses with the team for the past number of years. I would like to remind everybody that we have 2 channels. So at the end of this session, if you want to join the next session, you need to log out and to log into the next session, and that all sessions are being recorded and will be released starting next Tuesday. I'd like to now introduce our first speaker, and it's Professor Andrew Argent. He is from South Africa, and he is the director of the largest pediatric intensive care unit in Africa. He's past president of the World Federation of Pediatric Intensive and Critical Care Societies, and he's a particular interest in the appropriate responses to severe sepsis in children, particularly in the poorer countries of the world. So thank you very much, Andrew, for joining us this morning. Over to you.
Well, thank you very much, Vida, for that introduction, and a huge thank you to the organizers for inviting me to speak. And over the next 10 minutes or so, I'm going to be focusing on what I believe are unique considerations of sepsis in children. I'm going to start by looking at a little bit of the overall context of children in terms of mortality and infection, and then focus a little bit on why children are different, and as we seek a definition that helps us to identify patients early and provide appropriate therapy, what are some of the things that we need to think about? So that's a picture of the world reflecting where the deaths in children occur. And you can see the massive overpreponderance of under 5 deaths in Africa, in Asia, and tiny amounts of deaths in the rest of the world. By contrast, the amount of research related to those specific areas is reflected in this map, with a tiny proportion of the science coming from the areas affected or where children are affected, and predominantly by infection. And I've used the presence of anesthetists as a surrogate for the resources available to provide critical care. And again, you can see that for Africa, most of the anesthetists are actually present in South Africa. And for Africa and Asia, there are apparently minor amounts of resources available for children. So that's the overall context. Now, some years ago, John Marshall made this comment in an editorial about sepsis, saying that constructive sepsis is complex because it has an infection and a consequence which relates to the host response. And that leads to the issue that you can't just deal with it by anti-infective therapy. But before that time, there was also a whole publication of the PYRO approach, saying that the response to infection depends on the predisposition of the host, the infective agent itself, the responses that it elicits, and the specific organs that are actually affected. And yet I would put to you that those constructs there totally underestimate the complexity of the wide range of organisms related to infection, from viruses, bacteria, parasites, fungi, and potentially other things that we don't know about. The massive range in predisposition. And I'm going to highlight later in this talk some of the issues about the genetics and the background that we haven't even started to address. And then I would put it to you that the children that we are looking at who are exposed to therapy, these infections, come in a huge diversity, and I believe are very different to adults. Is infection important for children? Well, here's some recent data from the Lancet looking by age category at the percentage of all sepsis-related deaths across the world in 2017. And what I want to highlight is this fact that in the early years of life, a huge proportion of the deaths are related to infection and the consequences of severe infection. And so whatever sepsis is, the congruence of children, infection, and death is highlighted, and I believe different to that that's seen in adults. Let's take an example very specifically in the area of COVID. And here's some data from the Western Cape in South Africa. A little earlier this year, when we'd had about close to 300,000 documented cases, at that time, we'd had over 10,000 deaths. At that time, it was 11,480. And I want you to see down in this corner here that when you look at the infections, there are hardly any in children. That may be a sampling error, but actually individuals less than 20 years of age made up less than 5% of the total infections. Most of the deaths happened in the 60 to 70-year-olds. The clinical manifestations of severe COVID in children are profoundly different to those in adults. You get the whole multi-inflammatory or multi-system inflammatory syndrome, and that just looks totally different to the acute appearance of COVID in adults. So that at least is some suggestion that the responses to infection may be profoundly different. I'd also put it to you that children are not a homogeneous group. There's this massive range from neonates through to young adults in terms of size, functional reserve, and this issue of ongoing growth and development. It's worth bearing in mind that small children have a fraction of the functional reserve from the cardiovascular, respiratory, and many other systems that adults have. They have tiny reserves related to nutrition, for instance. If you look at sepsis in children, there's a huge preponderance of viral infections as pathogens that cause severe infection. The responses to those infections are profoundly influenced by previous exposure and energy resources, which I'll come back to. And it's also interesting to ask the question, what actually kills children who get severe infections? Does that happen acutely with acute septic shock? Does it happen over a much longer period of time with ongoing infection, ongoing damage? And is the issue about a cardiovascular death, or is this related to brain damage and other organs failing? Here's just some data that has been highlighted by Harbison and others in Frontiers in Immunology some years ago, looking at the differences between adults and neonates in terms of the use of energy in response to infection. And what it's highlighting is that adults in general have a huge reserve of energy, which is not being used, which is available to fight infection. And so they often use huge amounts of energy in the inflammatory response to infection. By contrast, neonates have a tiny reserve of energy. And in fact, they can't use that energy to fight the infection without risking vital functions. And the consequence of that is that they tend not to have a massive inflammatory response. That's why you tend to find many more bacteria in the blood in small infants than you do in adults. And that's why also the response to the infection is profoundly different. And so we have this issue that children are affected by severe infections are in a different context. But I want to put something else to you, and that is that most of the pediatric literature comes from rich countries, and the laboratory tools for diagnosis are often not available in the poorer countries. Just to highlight the proportions of selected age groups in world population, look at this graph. What you can see in Africa is that 40% of the population is under 15, while some 3% of the population is over 65%, over 65 years. Compare that to Europe, when those proportions are almost equal. So children in Africa are a much more important or numerate part of the population. There's also a fascinating issue that if you look at genetic diversity, here's this paper showing that as you go further and further away from Addis Ababa, you find a drop in haplotype heterozygosity. What that means is that you have a much higher genetic diversity among the children in Africa, and that has huge implications for being able to find and work through research issues on genetic contributions to responses to infection and susceptibility to infection. And so, trying to put that all together, I would put to you that children die in their thousands every day, predominantly in the poorer countries of the world. Most of our research comes from rich countries and is ICU based. If we want to address the issue of mortality and morbidity from severe infection in children, we need to focus broadly, not just on what happens in the ICU, what happens all the way from first exposure to an infection all the way through to death. It would be in everyone's advantage to carry out research in Africa, because with the increased genetic diversity, there's a much higher chance that we will actually find genetic underpinnings and factors related to responses to infection. And besides, we have many patients in that area mostly affected. And right now, it seems to me that many of the tools that we use to try and diagnose infection are geared to adults, to the needs of those adults, and to adults in rich countries, and would do us a huge amount of good to actually focus on tools that are appropriate to the children who are most affected. So thank you very much for your attention, and I'd be very happy to answer any questions.
Thank you, Andrew, for a very stimulating presentation. There are greetings from all over the world, every continent of the world coming your direction. So we have a very wide audience listening to us this morning, this morning from my time, which is fantastic. Pediatric sepsis is difficult. It's difficult to recognize. And the treatment is certainly in the initial response is much more controversial than it is in the adult. And there are also issues in relation to nature versus nurture in the risk of mortality associated with sepsis. Would you like to comment or give us some advice on how we can address those issues of recognition, but also recognizing that there are nurture implications in outcome?
So I think it's very difficult to respond to that. So I think one concern for me is that we very often focused on the critical care side of infection. And yet, if you're dealing with a population that has limited reserve and tends to get sick and very sick very quickly, you need to focus very definitely on the emergency department, the earlier issues of presentation. But the problem with that is that in that phase, the proportion, for instance, of febrile children who presenting, who actually have a severe infection, will go on to severe problems, is very small. And that makes the whole issue particularly challenging there. And again, you're absolutely right on this issue of nurture versus nature. I think when one looks at conditions like asthma, one's realized that the immune response to any infection is profoundly affected by what you've been exposed to before, what your nutritional status is, what your genetics are. And it seems to me that many of the children with severe infection who are suffering consequences may have profoundly different early responses to the children in the rich countries of the world who have, in many cases, long-standing underlying disease and immune suppression, and extremely different to the adult. I've highlighted some of the issues about the energy consumption, but you're absolutely right. There's evidence, for instance, that the vaccine profile that you've been exposed to affects how you will respond to infections early on in life. So those are areas where we're just going to have to explore in more and more depth what happens. I think the last comment is that if anything has come out of the FEAST study some years ago, there were things that we were pretty sure we knew all about. And yet that study showed us that we didn't know as much about fluid therapy as we thought we did in sepsis, and that actually the responses were not what we believed were the case. And interestingly, I think that shook things for adults as well as for children. Thank you.
It's always good to be shook, isn't it? Thank you very much, Andrew. So I'd like to introduce our next speaker, Professor Flavia Machado from Brazil. Flavia is Professor of Intensive Care and Chair of the Intensive Care section of the Department of Anesthesiology, Pain and Intensive Care Medicine at the Federal University, excuse me, of São Paulo in Brazil. She has worked with the Latin American Sepsis Institute since its inception in 2005. She's a member of the Surviving Sepsis International Guideline Committee since 2000 and the 2012 version, and she provides the perspective of low and middle income countries into that group. She's also a founder member of the Global Sepsis Alliance and its Quality Improvement Committee in particular. Thank you, Flavia.
Thank you, Vida, and it's a pleasure to be here. I've been asked to discuss a little bit about recognizing COVID as sepsis. So let's go for that. As you might remember, we have a new definition of sepsis, which is the sepsis 3. And sepsis is a life-threatening organ dysfunction caused by a dysregulated host response caused by an infection. So my task is easy. I should only convince you that we have these 3 points in COVID. I would say there is no doubt that we have an infection, SARS-CoV-2. And yes, I think that we have this related host response. We have a direct lesion for the virus. It is different. Nobody's saying that the mechanisms, the cellular mechanism, the inflammatory dysregulation is the same of sepsis, but we all recognize similar pathways and similar scenarios that we are quite used to see in our bacterial septic patients, let's say so. When you see an ARDS patient, we are seeing the same profiles, the same pneumocytal problems. We are seeing the membrane hyaline, we are seeing the pulmonary edema. When we are talking about this hallmark problem in COVID, which is the prothrombotic problems that we have, we know that it's different from sepsis because in sepsis, we mostly have microcirculation problems, and we are seeing much more in COVID arterial thrombosis and major venous thrombosis. But yes, we already had this in sepsis. And yes, there is a lot of dysregulated response when we talk about these mechanisms in thrombosis. And of course, I'm not going to go deep on this because it's not the point that we want to make here. We want to make the point that we have similar findings when we discuss bacterial sepsis back on to 20 years ago. When we start to deal with the thrombosis issues in sepsis, we have been trying to treat the microcirculation problem in sepsis for many, many years. And let's say without any success. And yes, for many, many years, we discussed that bacterial sepsis, that sepsis, it was an endothelitis, a disease from our endothelial cells. And again, now with COVID, we are saying that COVID is an endothelial disease. So there are so many similarities in terms of the physiopathogenic of this disease that I would say that the second point, dysregulated host response, it's also fulfilled. And there's the third point. Is there a life-threatening organ dysfunction in our severe and critical cases of COVID-2? Yes, for sure. We have a simple description of what COVID can cause in our body. We are so used to see this in our critically ill patients. And yes, they are dying from this. This is a simple description of the cases that we have been having in our service. You all know that Brazil is the epicenter of COVID now. We are losing 3,000 or 4,000 people every day. And most of these cases, they are dying from refractory septic shock. They are dying from multiple organ dysfunction syndrome. They are not dying from pneumonia only or a direct lesion of the virus in our lungs. And yes, they are dying. The mortality rates, at least in Brazil, and I believe in many middle-income countries, is very high. We have a program in Brazil. It's called UTIs Brasileira. It's a joint initiative between EpiMed and AMIB. And they are free for anyone who wants to fulfill quality indicators. And for this, we already see that there is this will be biased results towards qualified ICUs. They are able to have this all this data because the workload to have data collection is high. But let's have a look. They already have data for more than 130,000 COVID patients, and this is quite regularly updated. And as you can see, when you look, for instance, on the mortality rate for mechanical ventilated patients, this is very high. This is up to 68%. And that's a slight difference between public and private institutions. Of course, when you look at the overall ICU mortality, there is a huge difference between public and private, but this is because of the disparities in the ICU criteria admission. But the point that I want to make, at this is definitely life-threatening. And we also have more data coming from Brazil. And again, I believe that we have probably the same results coming from other middle-income countries. And this is very nice paper coming from the group of Fernando Boza. They published the data from the first 50,000 hospital admissions in Brazil. And again, what we see is that at least in patients that goes through invasive mechanical ventilation, the mortality rate is quite high, even in patients that are quite young. There's another thing that is important with COVID, and it's important for sepsis, which is the unique opportunity for research. We have a problem with sepsis, which was the heterogeneity, because we have all these infectious agents involved, and now we have a single agent in thousands of patients, which allow us to improve our research capacity. And this is happening in our countries, in high-income countries, but also in low and middle-income countries. And this is just an example of what we have been doing. In Brazil, we have this joint initiative between BRICNet and other institutions. And why I'm telling you this? Because there is another similarity between sepsis, bacterial sepsis, let's say, and what is happening with COVID, which is this. The survivorship was considered a research opportunity, an important thing that happens with our regular sepsis. And now we're seeing the same problem with the COVID patients. And actually, this is one of the major studies that we've been doing in coalition, which is the long-term follow-up of these patients. And part of these results have been presented in a WHO meeting by Regis, which is the PI of this study, and the results are not good. We've been already following more than 1,000 patients for 9 months now, and both readmission and mortality for these patients, mostly those patients that have been in ICU and in mechanical ventilation, are pretty high, as it is high for those patients who had regular sepsis, bacterial sepsis. And there is another point which is important. COVID, at least in our settings, which we already knew, we have a lot of problems with healthcare associated infections. We have a lot of problems with multi-drug resistance. And now with COVID, we are having serious problems with the coexistence of this in COVID patients. So of course, we have a lot of nosocomial superinfection in COVID. And we are having also problems with the sepsis in non-COVID patients because the basic healthcare, it's much worse. After 1 year of pandemic, our system, our healthcare system that have been prioritizing the COVID patients in the last year, unfortunately, are not taking care in a good manner of our non-COVID patients. So the numbers for sepsis in this last year are also probably much, much higher. So why all this? It's so important. It is because the strategies to deal with both problems are similar. It doesn't matter if sepsis is caused by a bacteria, a virus, a fungal. It matters that we have to do similar things to prevent and to diagnose and to deal with it. So prevention for COVID, it's vaccination, it's a good hygiene, it's to preventing death by COVID, it's to prevent the healthcare associated infection, which is, as I said, is a huge problem in our settings. Increasing the perception for the problem, it's a good strategy for COVID, and it's a good strategy for any sepsis. Early diagnosis is important as well. It's not just a matter of giving antibiotics at the first hour. It's a matter of going to the hospital early in the process of the disease and receiving adequate treatment. And of course, as I just showed you, the long-term follow-up and the rehabilitation process of this patient is important regardless the causative agent. And most important, it is to convince our governments that sepsis brings a huge burden to our healthcare system, regardless if it's a virus, a bacteria, or a fungus. So what we expect that after all this nightmare of COVID, it does leave us a legacy. It leaves us a legacy in terms of the perception of all disparities we already had with bacterial sepsis, with our previous burden of sepsis. And we expect also that all the improvements we had with the communication, with the teamwork, with the awareness about the problem can be inhibited and keep on the track our fight against sepsis. Thank you very much.
Thank you, Flavia. So Flavia, I think much like cancer, sepsis has a collective of diseases that cause it, but with a common presentation, a common phenotype, and a common, at least initial strategy in caring for the patients that then gets nuanced to the individual response. And I think that when COVID arrived, it was a new disease which came in very large volumes. which is a tremendous stress to the system, not just at a delivery, from a delivery point of view, but from an individual clinician. How do I treat this patient in front of me? This disease is new. How do you think the organizational structures of the Surviving Sepsis campaign and the Global Sepsis Alliance can help reduce that burden on the individual and indeed on organizations in managing these new diseases?
I think that both organizations you mentioned are doing a great job on this. For instance, the Surviving Sepsis campaign is releasing guidelines and they are updating this. We are, because I am involved actually, releasing updates on COVID in a rate and a speed that we have never seen before. For just an example, for the regular Surviving Sepsis campaign, we have updates every 4 years, and we are already preparing the third version of the Surviving Sepsis campaign on COVID. And this is directly linked with the fact that we are generating evidence very quick. As I mentioned briefly, it is a unique opportunity to improve our research capacity and to find out things that we were not able to find or to with a regular sepsis, because as you said, we have a single agent and thousands of patients to do research. So this is a very good thing from the point of view of Surviving Sepsis campaign. And I believe that we in Global Sepsis Alliance are doing a great job as well, because we are trying to link all this, which is happening, with the fact that sepsis is a great umbrella, and that we need to focus all the energy that we are spending with COVID and bring this to the fight against sepsis, because actually it is the same thing. We are fighting against a viral sepsis, and all the structure that the countries are building in this fight should be transferred to the fight against sepsis, because we should never forget that we lose thousands and millions of lives, thousands in my country, millions of lives in this planet for sepsis every year.
Thank you, Flavia. And I think the research and the multinational collaboration and the very quick publication of results in really good, well-structured trials has been really helpful in guiding us in our care of patients with COVID over the past 18 months. So that's been huge. And there's incredible work done in Brazil as well in supporting the development of vaccination and data around the effectiveness of our vaccines. So thank you for all of the work that you've been doing, Flavia, and thank you for your time. I know you're very busy intensivist at this time. So I'd like to move to our next speaker, who's Dr. David Barr, who's a lecturer in infectious diseases in the University of Liverpool and an honorary research associate at the Liverpool School of Tropical Medicine and the University of Cape Town. He is a specialist in infectious diseases, and his main interest is in HIV-associated tuberculosis. So he is going to speak to us this morning about sepsis and Mycobacterium tuberculosis. So thank you very much, David.
Thanks very much for the introduction, Vida, and thanks for inviting me to give this talk. So this is really a talk on severe HIV-associated tuberculosis, because that's the leading cause of sepsis in many high HIV burden settings. But it's also a talk about how host response relates to microbial factors like microbial load, using HIV-associated TB as an example. So I hope it will be of some interest to sepsis researchers, even in low HIV burden settings. And pathogen factors, such as microbial load, they're often acknowledged in sepsis discussions, but they're rarely measured in sepsis research. And I just want to show you an example of what you find when you are able to measure microbial load. So the first point to make, though, is just to show how dominant TB is as a cause of sepsis in some high HIV burden settings, particularly in sub-Saharan Africa. And there have been a number of groundbreaking studies that have shown this in the last 15 to 20 years. Just two examples, the SSSP trial from Zambia and the PRISM-U study from Uganda. Both of these were studies of hospitalized patients with sepsis and predominantly HIV-positive patients. And they were studies of sepsis interventions, but they also collected data on the microbiological etiology of sepsis in those settings. And both these studies found that TB is more common than all the other identified pathogens put together. So essentially, the probability of having TB, given that you have sepsis in a high HIV burden setting such as these, is really high. So what if we look at it from the other side and say, well, what's the probability of having sepsis, given that you have been hospitalized with HIV-associated tuberculosis? And here I think the plot thickens a little bit. And I'm going to show you some data that speaks to that from a large cohort study called the KDH-TB study. So let me just introduce that study first. The KDH-TB study was a large cohort recruited in Kailicha Hospital in South Africa. And the study was run by Graham Menkes and Charlotte Schutz at the University of Cape Town. And this study recruited patients with a suspected new diagnosis of HIV-associated TB, patients that had a CD4 count less than 350. And the study did extensive baseline sampling of these patients, including TB diagnostics, and ultimately recruited 570 patients with a final diagnosis of TB, of HIV-associated TB. And of these 570 patients, 21% died by 12 weeks follow-up, with most of those deaths occurring in the first 2 weeks. So a similar kind of survival curve to a severe sepsis population in a critical care unit. Looking at those 570 patients with their high mortality, as you would expect, they do have a high prevalence of host responses associated with organ damage. But interestingly, sepsis scores such as QSOFA, SIRS and SOFA are not well tuned to this patient population. There's very little agreement between those different scores, and perhaps more strikingly still, QSOFA is no better than a coin toss at predicting mortality in this patient group. So what about lactate and mean arterial blood pressure and septic shock in this patient group? Well, if you look at the distribution of venous lactate on admission in this study, it's very strongly associated with mortality. But mean arterial blood pressure on admission is not strongly associated with mortality at all. And more strikingly still, there's no correlation between lactate and blood pressure in this patient group. There is perhaps some suggestion that patients who have both a high lactate and low blood pressure do particularly badly. But this is not a phenotype that is common in this patient group, including in those patients that ultimately die. So what does drive mortality in patients hospitalized with HIV-associated TB? Well, it turns out that in critically ill patients with HIV-associated TB, probably the majority of those patients have TB bloodstream infection. TB bloodstream infection is something that the textbooks will tell you is quite rare, but it's only rare in low HIV burden settings. In settings where there's a lot of HIV, it's extremely common. I'm showing you some data here from a 7,000 patient IPD meta-analysis, which adjusted for factors such as how many blood cultures were done to identify TB bloodstream infection. And it found that in patients that were hospitalized and that were danger sign positive, which is a WHO metric looking at things like raised respiratory rate, raised heart rate, and inability to walk unaided, once CD4 count falls below 100, probably a majority of these patients have TB bloodstream infection. And more strikingly still, having the blood culture positive disease is strongly associated with mortality, particularly early mortality. And this association persists after adjusting for factors such as CD4 count. So it's not a kind of epiphenomenon of immunosuppression, but is possibly more causally linked to the outcome. Now, TB blood culture is only one way to identify and quantify TB dissemination or TB microbial load in these patients. There are also urine antigen tests for TB, urine lipoarabinomannan, and also the use of commercial PCR kits like the Expert system for identifying TB in urine. And these both report on TB dissemination from the blood into the renal tract. And we've also developed a method for using this PCR method directly on the bloodstream. And if we just take those 5 tests and kind of add them up into a very simple score, which we'll call the disseminated TB score, ranging from 0 if all those tests are negative to 5 if all tests are positive, we can get a kind of simple readout on the degree of TB dissemination. I'm going to come back to that score in a couple of slides' time, so just hold that in the back of your mind. But first, I want to come back to the host response in this patient group. And the KDH-TB study measured a large number of markers that are putatively associated with sepsis. And I'm showing you here 20 of those markers, mostly soluble immune markers, but also factors like lactate, CRP, neutrophil percentage, lymphocyte counts. And if we look at those 20 variables, we find that there's a lot of covariance between them, and we can kind of summarize the variance in all 20 of those variables, or summarize about half the variance in all those 20 variables on just 2 axes of a principal components analysis. And this captures a very meaningful representation of patient phenotype. If we plot patients by their PC1 and PC2 scores derived from those variables, we find that patients that are scoring above mean on PC2 and below mean on PC1 have about an odds ratio of 9 compared for death compared to patients in the opposite quadrant of that PCA space. So it's a kind of low-dimensional, robust representation of patient phenotype that relates strongly to mortality. Now, the interesting thing is that if you then map this disseminated TB score onto that PCA space, it also maps extremely closely, with patients with more dissemination having a very different location in that patient phenotype space compared to patients with a low disseminated TB score. So I think this is fairly convincing evidence that this kind of microbial load variable is an underlying latent variable that's driving both patient phenotype and risk of mortality. To put that another way, I would say that being able to measure this variable allows us to interrogate host response in interesting ways. And I'm just going to, on my last slide here, show you an example of that, a sort of simple example relating to patient temperature, infection load, and death. And I think we would all agree that temperature is associated with infection. And I think most people would agree that temperature tells you something about patient's prognosis or risk of death. Certainly having a hypothermia in severe sepsis is a very bad prognostic indicator. And perhaps also having a very high temperature, that is a sort of dysregulated temperature, might also be associated with mortality. So if we take that kind of causal structure that we're hypothesizing and we use that to build a regression model that allows there to be an interaction between disseminated TB score and fever in terms of how they predict death, we find something quite interesting, which is that the relationship or the shape of the relationship between temperature and risk of death varies depending on how much disseminated TB you have. So patients with a low disseminated TB score, in purple on the graph, have this kind of classic U-shaped relationship, but patients that have more disseminated TB, having a lower temperature is always worse. It's always more prognostically bad, even within the normal range of temperature. So one of the implications of this is that the apparent relationship between fever and mortality will depend on which patients you recruit to a study. So that's a so-called Simpson's paradox. And I wonder how much of this type of thing is going on in sepsis pathophysiology studies more generally, particularly in studies that aren't able to measure microbial load. Okay, so briefly, some conclusions. The probability of TB, given that you have sepsis, is not the same as the probability of sepsis, given that you have TB. And many patients with severe HIV-associated TB die without presenting with a kind of septic shock type picture. Causative pathogen, I think, is a really good place to start when you're thinking about heterogeneity in sepsis phenotype. HIV-associated TB in critically unwell patients is essentially a bacteremic illness, irrespective of what the textbooks will tell you. And finally, microbial load is a fundamental determinant of clinical immune phenotype, at least in HIV-TB, and it's a variable that helps us interpret host response. So I've just put up a thanks slide. Particularly want to thank the Menkes Group, the University of Cape Town, and also some of the guys in Liverpool. Thanks for listening. Happy to take any questions.
Thanks, David. So we have a question here. What do you think about using blood cultures to detect TB? I suppose in the general population, and then perhaps in the more specific population that your talk is based on.
Yeah, that's a great question. And I should emphasize that I think blood cultures are not very useful clinically. And the reason for that is it takes an average of about 20 days to get a result from a blood culture for TB. And as I showed you, the mortality in this patient group is very high within the first 2 weeks. So they're a useful, I think, tool for understanding what's going on pathophysiologically, but they are not a useful tool clinically, irrespective of the fact that they're simply not available in most settings, in most particularly low resource settings. But what we do have is other markers of TB dissemination, which are rapid diagnostics, such as the expert platform and such as those urine antigen tests. And if you are dealing with patient populations like this, that's where you would want to focus your diagnostic strategies.
Well, thank you, David. And the persistent bacteremia and the association with mortality, is that a marker of the failure of the immune response to be able to control the load of TB in the system?
That's undoubtedly the case, and TB is a very difficult bug to kill. It's a very persistent organism generally. But I think it's also an argument that says, have we really optimized the antimicrobial strategies in this patient group? And the Menkes Group are now pursuing randomized control trials focused on reducing this microbial burden more rapidly in this patient group that have an extremely high microbial burden. But yeah, I think it's always worth, when we're thinking about host-directed therapies, always thinking, have we optimized the antimicrobial killing, which is a tried and tested method for saving lives in sepsis.
Yeah. And have you observed TB iris in your patients after TB treatment?
Undoubtedly, yes. These patients are at extremely high risk. They have a high microbial antigen burden and they have a very low CD4 count. And I would probably say the majority of these patients have a TB iris. And certainly the work from Cape Town that the Menkes Group and others have done have shown that. And that iris occurs really early in this patient group, even within 7 days of starting ART, which is quite interesting.
And in sepsis, we talk about a bundled approach to care. How different is the treatment of sepsis due to TB from other sepsis due to other causal agents?
That's a great question as well. And we simply don't really have the evidence base, do we? Because, the number of trials haven't been done. I did mention the SSSP trial from Zambia. I think a lot of this audience would be familiar with. It was a trial of kind of more aggressive fluid resuscitation or a sepsis bundle that showed a higher mortality in the intervention group. And I wonder if one of the reasons for that was because actually the majority of patients in that study had HIV-associated TB. And these are not patients that are necessarily presenting with septic shock type picture. They're perhaps patients that are profoundly fluid and electrolyte deplete over several weeks, and sort of dumping a lot of fluid into those patients whenever they have physiologically adapted to that state might be more adverse than in a patient that has developed rapidly septic shock over a 12-hour period. So I think there's a lot of work to be done there, Vida, and I don't know we have good answers to that, but we should absolutely be taking into account the causative pathogen when we're designing those intervention studies in sepsis, I think.
There's certainly a lot of interest in this subject. People are asking about vaccination for TB as a strategy in prevention after COVID. They're asking about AMR in TB. And I'm interested if COVID has caused a lot of disruption in non-COVID care. Are you worried about how that undelivered non-COVID care may be impacting your patient population?
Yes, undoubtedly, and there is certainly some early data that is suggesting that we could be hit with a wave of TB and a wave of HIV-associated TB in high HIV burden settings after the disruption caused by COVID, which is a terrifying prospect. Sadly, we don't have effective vaccines for TB. We have a 100-year-old vaccine that there really hasn't been the appropriate investment, and I hope one thing we can learn from COVID is that investing heavily in vaccines can dig us out of these problems, but it remains to be seen whether the international community fund that, because this is a disease of poverty. So we'll see. But thank you for bringing that point up.
Well, thank you very much, David, for a very interesting talk. We're going to move to Dr. Sophie Yacoub for our next speaker. So just a slight change in the order of presentations. And Sophie's going to talk about sepsis and dengue. She's the head of the dengue research group in the University of Oxford in Vietnam. She's a physician in infectious diseases and general medicine and is currently leading a large translational program of dengue research. She's also working on mosquito viral transmission dynamics with the aim of disease prevention. And her overall aim is to improve the management and clinical outcome for patients with dengue at a global level. So thank you, Sophie.
Thank you very much for the introduction. So I'm going to talk today about the pathogenesis of dengue. I just wanted to mention that, well, I'm going to talk about mainly our research into the pathogenesis of severe dengue today. But just to give a quick background to those who don't know much about dengue, it's a mosquito-borne viral illness that actually made it onto the top 10 threats to global health by the WHO in 2019, mainly because it continues to expand across the globe and we still don't have any therapeutics and a poorly effective vaccine. So I work in Oxford University Clinical Research Unit, which is housed in the Hospital for Tropical Diseases in Ho Chi Minh City, which is a large referral hospital, which covers the whole of southern Vietnam. So we see a huge burden of dengue every year, up to about 15,000 dengue admissions, of which up to about 500 will be admitted to the intensive care unit. And this is the pediatric intensive care unit during the rainy season, where every single bed that you see there is occupied by a dengue shock case. During the peak of the rains, when the dengue cases really surge, a lot of those beds will be occupied by 2 or 3 children. We're also seeing a lot more adult dengue, and these cases present slightly differently in that they don't get the pure shock that we see in the children. They get often severe organ impairment and more hemorrhage. So severe dengue does cover these 3 syndromes, shock, hemorrhage, and severe organ impairment. Sometimes they happen all 3 of them, and it depends also on age of the patient. So unlike sepsis, dengue takes a few days to evolve. So during the first few days, what we call the febrile phase, the viremia is already peaking, usually by the time a patient presents. And during the first few days, the inflammatory response starts, the capillary leak will occur. And this usually manifests in what we call the critical phase, where patients can decompensate with either shock or bleeding or organ impairment. So a lot of the work we've been doing here in Vietnam is trying to identify which patients will go on to get these severe manifestations, as the vast majority will just progress into the recovery phase without any complications. So it's really identifying which patients, because during this rainy season, the amount of dengue patients we see is so huge, it can absolutely just collapse the healthcare services. So what we've been trying to identify is patients that will go on to get severe disease by trying to understand the pathogenesis more. And what we do know is that the dengue virus replicates in monocytes and macrophages. And in a secondary infection, so because there are 4 serotypes, if you get a second infection with a different serotype, you can often get more severe disease. And this is due to this phenomenon called the antibody-dependent enhancement, whereby subneutralizing levels of antibodies can actually facilitate viral entry into cells rather than block the virus. So once you have a higher viral load, this can often then precipitate a more of an intense immune response, more hyperinflammation. Also, dengue-infected cells secrete NS1 protein, which binds to the endothelial cells and disrupt the endothelial glycocalyx layer, which we think is what causes the plasma leakage that's characteristic of severe dengue. So this is not unfamiliar. So what we've seen recently with SARS-CoV-2 is that many other viruses can cause this hyperinflammatory syndrome or a cytokine storm syndrome, SARS-CoV-2, Ebola, influenza, to name a few. So there are a spectrum of viruses that can cause this syndrome. And what happens once the virus infects the dendritic or macrophages, and there's macrophage activation, in patients that have a dysfunctional NK cell response, the macrophage activation actually sort of perpetuates with more cytokines being produced, and then this sort of gives a vicious cycle of this hyperinflammation that is sort of self-escalating. And what we're looking at the moment is whether, as in COVID-19, we can use immunomodulation to block this hyperinflammatory syndrome. So over the last few years, we've been looking into this a bit more, and we hypothesized that patients would have a reduced NK cell response, which would lead to macrophage activation, sort of syndrome, expansion, augmented viral replication, and this release of cytokines. And then this would manifest as the severe syndrome that we've been seeing, again, similar to the sort of COVID-19 patients. So first we looked at NK cell function in a range of dengue severities, and this was done in collaboration with Laura Ravino at the University of Bristol. And we looked at NK cell responses in different leakage grades of dengue. So grade 2 is patients with severe plasma leak, so patients with shock. Grade 1 is moderate leak, and grade 0 is no evidence of leak. And as you can see in the top left panel, there were less activated NK cells and also less expression of granzyme and perforin, which are cytotoxic granules. So we then went on to look at, with some colleagues in the dengue group at OCRU, at the association of viremia and a clinical outcome, and we looked at 3 different endpoints in a large pooled data set that has been accumulated in OCRU over the last 10 years, looking at severe dengue, also plasma leak and hospitalization. And across the board, we did find that higher viremia was at increased risk of developing all 3 of these endpoints. And this was consistent across age groups, across serotype and immune status. And as you can see here, these are the different serotypes of dengue. And then you've got severe dengue at the top, then plasma leak and hospitalization at the bottom. And the red line is primary infections, and the green-blue line is secondary infections. And you can see across the board that the higher your viral load, the more likely you are to have all of the 3 severe outcomes. And this was more pronounced in the secondary infections. And then moving on to cytokines. So we looked at IL-1 pathways, which IL-1 is one of the key cytokines in the cytokine storm. And we measured IL-1 RA levels as a surrogate for IL-1 activity, as this has a longer half-life and is easier to measure. And again, you can see in severe dengue patients, in the first 3 days of their illness, actually IL-1 RA levels had already peaked by day 1 of illness. And this was higher in patients that went on to get severe dengue later on during the critical phase, which is day 4 to 6. But we only wanted to measure the first 3 days of illness because we wanted to use this as a potential biomarker for disease progression. Then we went and looked at just a general inflammatory marker. So we looked at CRP because obviously this is very easy to access in many dengue endemic areas, and there are point of care tests. And we used an IDAM study, which was a study of 6 different countries in South America and in Southeast Asia. And we looked at, again, severe outcome, but we also looked at other febrile illnesses to see how CRP performed in dengue patients compared to other febrile illness. And we found that actually CRP in dengue patients had a sort of median level between 20 and 30, which is higher than other viral infections, but lower than bacterial infections. And we also found that CRP was associated, higher CRP levels was associated with severe dengue outcomes. So again, this is looking at your CRP levels at the bottom and your odds of developing either severe or intermediate dengue at the top, fever clearance time at the bottom left, and your chance of hospitalization. And as you can see, really above 30, you start seeing higher levels of hospitalization and severe outcome. And then finally, we looked at a different set of biomarkers and tried to see which was the best combination, knowing that the vascular and the immune and inflammatory pathways are all the key pathways in dengue pathogenesis. So we looked at 10 different biomarkers, really from pilot data that we already knew some of these biomarkers were useful, and also what were performing well in other studies from the literature. We used the same IDAMS study and had 281 cases and compared to 500 controls who were uncomplicated dengue to see how they would perform singly and also in combination. And just to say, first of all the biomarkers that we looked at, again, in early disease, so disease illness days 1 to 3, and then we looked at a follow-up period on sort of day 10 and day 20. All of them showed that they were associated with a higher risk of the severe outcomes. And again, you can see quite different trajectories. Again, IL-1RA levels were peaking very early on, whereas things like ferritin was just starting to climb after sort of day 2 or 3. And then when we looked at them together with the hope that we could try and combine some of these biomarkers, possibly in a lateral flow test, or again, a point of care of 2 or 3 of these biomarkers to see if we can predict patients that would go on to get severe disease. So we looked at different subsets. And first of all, we noticed that there was a difference in the biomarkers between age. So we separated them, looked at children first. And you can see ferritin, IL-1RA, were probably the best of 2, and then angiopoietin 2, best of 3. And as you can see, as you add the biomarkers, it does perform a bit better. And these were slightly different for adults. So of best of 2, we were looking at Syndecan and IL-1,8. And again, when you look at best of 3, it was ferritin and so on. So overall, I think the best subset for children and adults can be seen at the bottom of the slide. And these markers now need sort of validating in another data set. So apart from using some of these pathogenesis studies to guide biomarkers and try and understand who is at higher risk of severe disease, we also want to use these studies to guide host-directed therapeutics and clinical trials. So the first few drugs you can see at the top, these are what have been tried already in dengue and have not shown any significant benefit. And I think really the main reasons for that is that they used a unselected patient group. And I think what we have learned from this and from other studies is that we really need to target patients better and go for patients because they will respond very differently to the virus. And we want to really use some of the pathogenesis work that we've done to target patients using specific immunomodulators, and we're looking into anakinra and baricitinib at the moment. So with that, I think that's my last slide. Yeah, just wanted to summarize that what I've shown is that dengue does cause this hyperinflammatory syndrome, and what we've seen in other viruses, this can be a target of immunomodulation, and we really need to now apply some of this knowledge and other knowledge that we've learned from SARS-CoV-2, for example, to try and apply this now for dengue, where we still have no therapeutics for. And I'd just like to thank my group here in Ho Chi Minh City, collaborators and funders at the bottom, and I'm happy to take some questions.
Thank you, Sophie. So our first question is there any evidence of red blood cell involvement in the severity of disease?
No. They across the board, everyone will get some element of thrombocytopenia, but no, not red blood cells.
Okay. And how do you combat the false positivity of dengue in COVID with regard to management, especially in non-dengue season?
Yeah, so we haven't seen that much. I know there are reports that have come out of Singapore, for example, but I think the clinical syndrome is quite different, especially once you get past the sort of second or third day, and that you don't get any respiratory symptoms early on in dengue, and often the blood picture is quite characteristic. So you will start to see thrombocytopenia from day 2 onwards, and the sort of lack of respiratory symptoms should guide you more towards dengue. And the NS1 rapid tests are pretty good, but obviously there are these concerns that you can get some false positives.
And dengue is vector transmitted, and COVID aerosol and fomite transmitted, but has there been any impact on the instance of dengue due to the movement restrictions or change in practices that have occurred during the COVID pandemic?
Yeah, so I mean, that's been quite different between the different countries, actually. So during lockdowns, actually, there was an increase in dengue transmission in Singapore, and they've seen a very large outbreak there. However, in other places, which could be more work-related transmissions, they've seen a decrease. And actually, we had one of the quietest dengue years last year, but I think that's probably for a number of reasons, not due to lockdowns, because we really haven't had that many here in Vietnam. So I think it's setting dependent.
And you mentioned in your talk that a higher viral load is associated with worse outcomes. And I suppose this reflects back to my earlier question with relation to TB. Does this reflect the inability of the host to mount a meaningful immune response? And are there patient characteristics such as, pregnancy or underlying disease, comorbidities, or socioeconomic status that put people at worse risk of having a higher viral load and more severe dengue and poor outcome?
Yeah, so that's a good question. I think definitely the inability to mount effective immune responses there, and also in dengue you've got the antibody-dependent enhancement, so a secondary infection where you have this sub-neutralizing level of antibodies that facilitate viral entry. So there you will get higher viral loads, but I don't think there's data to suggest like pregnancy or other comorbidities would be driving that. However, if you do have a dysfunctional, for example, NK cell response or an early innate response, then yes, that would lead to higher viral loads. But I think that's probably more genetic factors rather than some socioeconomic or comorbidities.
And have you contemplated looking at the level of oxidative stress about biomarkers?
No, we haven't. I think there is a group in the Netherlands that are looking at that, but yeah, no, we haven't.
Okay, thank you. So I just to mention that there were greetings coming in from Georgia, from Africa, from New Zealand, from Romania, from France, from New Zealand. And so thank you very much to our audience. And thank you, Sophie, for a very interesting presentation. I'd like to move on next to our next presenter, who's Professor Arjen Dondorp, who's a specialist, did a specialist training in infectious diseases and internal medicine and critical care in the Academic Medical Center in Amsterdam. Since 2000, he worked in Bangkok, having joined the Machado Oxford Tropical Medicine Research Unit, and he's Deputy Director and Head of Malaria and Critical Care Department. He's a Professor of Tropical Medicine in Oxford and Visiting Professor in the University of Machado. His main research area is malaria. He's published more than 400 papers, and he is going to speak to us today about sepsis and malaria. And just before he starts, we will have an opportunity for further questions. So there's some questions coming in that we can address at the end of Professor Dondorp's presentation. So thank you, Arjen.
Yeah, thank you very much, Vida, for that nice introduction. So I've been asked to talk about sepsis and malaria. So I thought I'd take the same approach as Flavia earlier to evaluate a bit to what extent malaria fits the sepsis definition and the conceptual framework behind that. So severe malaria, it's a severe infection with a high case fatality rate between, say, 10 and 50%. Depending on the number of organs that are involved. If we look at the conceptual framework behind the sepsis 3 definition, then it's an invasive infection causing this dysregulated host response, causing this multi-organ dysfunction, and you see a list there in the slide. And then we have the SOFA parameters or variables to pick up those organ failures, and that determines the whether a patient is defined as having sepsis or septic shock, and it relates to, as a prognosticator, what the case fatality rate is. So for severe malaria, there's definitely a strong pro-inflammatory host response that we think contributes to respiratory failure. ARDS is a feared complication, should be treated according to the Surviving Sepsis campaign guidelines. There's dyserythropoiesis, probably also mainly caused by the pro-inflammatory host response, and it can also contribute to hepatic and renal failure. That said, trials that have been done with immunomodulatory agents like steroids or anti-TNF antibodies have not shown any benefits. At the moment, there's a trial going on with rosiglitazone for severe malaria in African children. So far, so good. Also, the Q-SOFA score, as a surrogate of the full SOFA score, performs very well in low and middle income countries, also in areas with a high malaria burden. So Q-SOFA is a good prognosticator, both in bacterial sepsis, but also in severe malaria. By the way, much better than the old SIRS criteria that we used previously. So if we go a bit deeper into the different manifestations of severe malaria, it's a multi-organ disease which depends on the age of presentation, which organs are most involved. So severe metabolic acidosis, you see in about half of the patients, both children and adults. And cerebral malaria, so irreversible coma, is also a very common manifestation, both in children and adults. Whereas hepatic failure and renal failure but also pulmonary edema is much more common in adults, whereas anemia, convulsions in the context of cerebral malaria is much more prominent in children, as is hypoglycemia. High hemodynamic shock is relatively rare in around only 10% of the patients. And I'll come back to that a bit later, which is because it's surprising that despite these high pro-inflammatory cytokines circulating, high nitric oxide levels, you still see relatively rare severe hypotension. So if we go through some of these manifestations, see how much of that is caused by the dysregulated host response or other pathophysiological mechanism. Cerebral malaria is really primarily caused by an obstruction of the microcirculation by parasitized red blood cells. So the parasite lives in the red blood cell, doesn't go anywhere else. With maturation of the parasite, the red cell becomes very sticky and starts to cytoadhere to microvascular endothelium, blocking the microcirculation. You see a light microscopic picture over there. And if you look in pathology studies, you can see that children dying from cerebral malaria and also adults versus patients dying from severe malaria, but not without coma, that this sequestration is observed much, much more extensively in patients with coma. It's one of the main indicators that it's the central part of the pathophysiology. In children also, cerebral edema plays a role later on in the course of the disease. So here you can't really say it's the dysregulated host response. You can't blame your poor patients from that. It's the sequestration of these parasitized red blood cell that cause coma. Similarly for the metabolic acidosis, which is mainly a lactic acid acidosis because of organ dysperfusion with anaerobic glycolysis causing a lactic acidosis. That also is in general not caused by macrocirculatory failure, so hemodynamic shock. It's again caused by blockage of the microcirculation by these erythrocytes in having the more mature forms of the parasite. And you see those pictures there above the 48-hour life cycle of the parasite. And once you start seeing the pigment in the parasite, the brownish pigment, that's when they start sequestering in the microcirculation. And you don't find them circulating in the peripheral blood, but they declare themselves because on Schizont rupture, that is the most mature stage, they release this parasite protein, HRP2, and the plasma level of that is a very good surrogate measure of the total parasite burden, and that correlates quite nicely with the plasma lactate levels in patients with severe malaria. Why don't we see hemodynamic shock? Well, we think that is because with the burst of the erythrocyte at the moment of Schizont rupture, 80% of the hemoglobin is eaten by the parasite, but the rest is released in the circulation. And the heme part of that is known to be a very strong scavenger of nitric oxide. And we have shown that indeed the plasma hemoglobin concentration correlates nicely with the vascular resistance that we measure. And then in the middle, you see again, it's a nice EM picture of sequestration causing a traffic jam behind the sequestered erythrocytes, blocking the circulation. So that's the cause of the tissue hypoperfusion. It's not shock or intravascular dehydration. Related to that, the microcirculation, unlike in bacterial sepsis, is not restored by fluid management. And that's probably best illustrated by the famous FEAST trial, where they showed that fluid bolus therapy increased mortality. The majority of those children, African children with compensated shock, in fact, had severe malaria. So almost 60% were malaria slide positive. And they had an almost doubling of their mortality when they were treated with fluid bolus therapy, either with saline or albumin. Big study, 1,000 patients in all the treatment arms. We also looked at this in adults with severe malaria, trying to fluid resuscitate them carefully under PICO guidance up to an optimal global end-diastolic index. After fluid resuscitation, that's this graph, the filling status did not correlate at all with the plasma lactate levels. In fact, there was an inverse correlation. So again, showing that it's the blockage in the microcirculation causing the lactic acidosis. The fluid therapy, although we tried to monitor that carefully, did cause pulmonary edema in quite a large proportion, around a fifth of the patients. Another important pathophysiological pathway, which has little to do with a dysregulated host response, is the circulation of free heme. I mentioned it earlier. It's not only a nitric oxide scavenger, but it's also highly oxidative, which is in particular damaging for the kidney. And we have shown that the concentration of cell-free hemoglobin correlates with acute kidney injury in those patients. And that also correlates with oxidative stress markers, isoprostane and isofuranes, correlating with renal failure. The nice thing about this is that the oxidative properties of iron, which is iron 4+ in this case, can be reversed by paracetamol. Paracetamol reduces ferral iron back to ferric iron, which is no longer oxidative. And we did a trial in adult patients. And in the patients presenting with high concentration of cell-free hemoglobin, paracetamol was very protective for the kidney, reducing the incidence of acute kidney injury, as you can see in the right graph there. So, does severe malaria fulfill the sepsis criteria? In part, it does. There is a high inflammatory response responsible for some of the manifestations of severe malaria, but there are clearly also direct pathogenic effects. And I highlighted the sequestration of the parasites, erythrocytes in the microcirculation, which is really the pathophysiological hallmark of severe falciparum malaria, causing coma, but also other organ failure, and the other important pathophysiological pathway of the oxidative damage caused by cell-free hemoglobin and the heme that elutes from there. So I think the conceptual framework for severe malaria needs to be adapted to that there are clearly direct pathogenic effects. In fact, I think that in many other severe infections, these direct pathogenic effects should be taken into account and be added to the sepsis 3 definition. So what can we do about those direct pathogenic effects? Not much yet, except for giving a very potent antimalarial drug. The best drug we have at the moment is parenteral artesunate, much better than quinine, both in adults and in children. It's very worrying, therefore, that now in Southeast Asia, especially in the Greater Mekong sub-region, we see artemisinin resistance emerging and spreading, and also increasing reports from some African countries, in particular Rwanda, that artemisinin resistance has emerged there. So we have to look at new potent antimalarial drugs that attack the ring stage parasites. And the spiroindolones, or KE609, is a promising candidate there. We are also looking at specific adjuvant therapies targeting infected red cell sequestration. And there is a candidate there, that's savuparin, which is a low molecular heparin that lacks the anticoagulant activity of the heparins, but does de-sequester sequestered red cells. It looks promising in uncomplicated malaria and will now be trialed in severe malaria in African children. So, in conclusion, severe falciparum malaria pathogenesis has unique future that has some fundamental differences from bacterial sepsis. Again, I mentioned microvascular sequestration of parasitized red cells and the cell-free hemoglobin-mediated oxidative damage. And this does have therapeutic consequences. So in order to address sequestration, we at the moment only have our antimalarial drugs, but there are some future therapies that are being trialed. The fluid management in severe malaria is much more restricted than in bacterial sepsis. And we have an adjuvant, very cheap, easy paracetamol to detoxify cell-free hemoglobin. That's it. Thank you for your attention.
Thank you very much, Arjen, for a fascinating presentation. We'll only be able to take a few questions because the next session is ready to start, and I'm happy to be able to tell everyone that Dr. Chisti has been able to join us. After all, he had some connectivity issues. But before we go to Dr. Chisti, a couple of questions. Is it true that paracetamol slows the clearance, parasite clearance? And therefore may also be harmful for the antimicrobial response?
Yeah, so there's one publication now around 10 years ago, I think, with the observation that in patients, children treated with paracetamol, the parasite clearance seemed to be slower. We could not reproduce that in our studies, and we even think that it is that observation is caused by the fact that fever increases red cell sequestration as an earlier stage of parasite development. So if you then block the fever, the parasites will circulate longer, a longer part of their 48-hour life cycle. And that might give the impression that you have higher parasitemia, whereas it's only the circulating peripheral blood parasitemia. So I don't think that that is the case, but it has been shown in that one publication.
Okay, thank you. And do you think there's an association with other hemolytic germs, Brucella, Staphylococcus, Streptococcus, Haemophilus? Are they promoters of mortality in malaria falciparum?
Yeah, that's a very good question. I didn't go into that. So in children with severe malaria, it has been estimated that more than 10% of the cases have concomitant invasive bacterial infection, which definitely also contributes to mortality. And therefore, the guideline for the management of children, African children with severe falciparum malaria, is to also give broad-spectrum antibiotic therapy.
Okay, so would you recommend vasopressors then rather than fluid boluses for the management of shock? And would you recommend low molecular weight heparin for all patients with severe malaria?
Yeah, the latter one still needs to be trialed, so I would wait for that. Giving vasopressive therapy is not needed in the vast majority of patients because only around 10% will have shock. I think in those patients, indeed, still you have to give fluid treatment, but I would be a bit careful and start relatively early with your vasopressive therapy.
Thank you so much, Arjen. I have to say I've learned an awful lot, and it's given me a greater understanding of the outcome of the FEAST trial. And I think understanding the pathophysiological process is so important in guiding our treatments of patients. So thank you very much for your talk. I am going to now move to Dr. Chisti, who thankfully has been able to join us here today. Dr. Chisti is from Bangladesh. His main research interest is in pediatric infectious disease. He has expertise in pediatric critical care medicine and respiratory medicine, and predominantly in those resource limited settings. And he's a particular interest in low-cost innovative work and scale up in resource-limited settings with the aim of reducing mortality in the under fives. So many thanks, Dr. Chisti, for joining us today.
Thank you very much. I'm really sorry that I joined at the last moment because I have been working in the COVID ward as in charge. I have a lot of bad patients, so excuse me, but I'm also think myself fortunate enough that eventually I able to make it. Thank you very much. I want to tell about the story of sepsis and diarrhea, especially children who used to present with diarrhea. So globally, as we know that in the under 5 mortality since 2000, there is significant reduction of deaths from sepsis and diarrhea. However, if you compare the sepsis-related death reduction to other diseases, you can see that we have only 30% reduction of death from sepsis, whereas in other diseases there is enormous improvement. That does mean that we have still a lot of things to do to have the further reduction of sepsis-related deaths. So when sepsis globally occurs, and if we see the deaths, that is among the 48.9 million people who had the sepsis in globally, there were 11 million deaths in 2017, representing almost 20% of the global deaths. And when it is associated with diarrhea, that is even higher. So reduction of mortality from sepsis also depends on early identification of warning signs, especially in case of if there is comorbidity like diarrhea. However, diagnosis of sepsis in diarrheal children is very tricky because of the fact that diarrheal children also used to present with dehydration. So there is masking of signs of sepsis in case of presence of dehydration. So we need to be very careful in those cases. So we do not know about the early warning signs, especially we don't have any published article for that. And what are the early warning signs in case of children who present with diarrhea as well as sepsis. So we wanted to evaluate the children who died at our Dhaka Hospital of ICDDRV, and we wanted to show what are the early signs. So for that, we actually conducted retrospective chart analysis in our Dhaka Hospital of ICDDRV for 1 year, and sepsis was defined very conventionally. That is tachycardia plus hypothermia or hyperthermia with abnormal WBC count plus presumed presence of infection. However, for the definition of severe sepsis, we modified the definition that we initially corrected the dehydration, or if there is no signs of dehydration, then we have took other signs of peripheral perfusion, that the poor peripheral perfusion as the other signs of severe sepsis, like that age-specific hypotension or absent peripheral pulses or delayed capillary refilling time. And all these are present in case of dehydration. So we need to have the correction of dehydration. or we need to be sure that there is no sign of dehydration. So when we compare the children who died at our hospital compared to those who survived, we have found that children who died more often had shortness of breath, and they were abnormally sleepy, that is, they were drowsy, and they presented with dehydrating diarrhea. And even after correction of dehydration, we found that those who died, most often they had presented with dehydration. And even correction after dehydration, we found that they often ended up with septic shock compared to those who survived. However, we didn't find any difference between the death and survivors among the laboratory investigation that we have done conventionally. Then we have done the logistic regression analysis. There's a multiple logistic regression analysis to understand the independent clinical predictors of death. For that, we put all the significantly associated variables. Those are found in chi-square test, and it has been found that shortness of breath, dehydrating diarrhea, and septic shock revealed as the independent predictors of death in case of children who admitted with diarrhea with or without the presence of dehydration. So from these findings, we can summarize that children who admit with diarrhea, largest diarrheal hospital in Dhaka Hospital of International Center of Diarrheal Disease and Research, they often had severe sepsis, and they had high mortality. And we have found that shortness of breath can be used as an early warning sign for the predicting of worse outcome in those children, especially with the non-dehydrating diarrhea and severe sepsis. That does mean that when we assess, there was no sign of dehydration, although some of them presented with dehydration. So identification of these simple clinical features, such as shortness of breath and septic shock, in predicting deaths in children under 5 years of age with diarrhea who were treated in Dhaka Hospital of ICDRB ICU for severe sepsis, may help to design further intervention studies that may further help to reduce mortality in such children, especially limited resources like Bangladesh and other developing countries. Thank you.
Thank you, Dr. Chisti. It's a very interesting presentation. The underlying driver for the shortness of breath, is that related to acidosis? Is it related to fluid overload, or can it be both, either, depending on the clinical scenario and the treatment given? What's your views on that?
Yeah, our understanding was that from previous data from other developing countries, this might be mostly due to metabolic acidosis and mostly due to increased serum lactate. But we didn't have that luxury to perform the serum lactate in our study population. However, we actually evaluated the metabolic acidosis, but it was similarly distributed in both the groups. So we didn't really we didn't know whether metabolic acidosis had a part in this population, but our understanding was that it was mostly due to metabolic acidosis. Yeah.
Okay, thank you. And therefore, what markers did you use to help you guide the safe fluid resuscitation of your patients?
Yeah, we actually used very conventional role, that is for children who For non-malnourished, we have given actually, according to surviving sepsis guideline, 20 ml per kilo fluid, up to 60 ml per kilo. But those who had severe malnutrition, we were a little bit conservative. According to WHO guideline, we provided them actually 15 to 20 ml per kilo over 1 hour, because of the fact that there is high chance of actually interstitial edema if we used to give very rapid fluid transfusion, rapid fluid infusion in case of children with severely malnourished. And mortality was very high among the children who were severely malnourished. We didn't show here in separately, but in that is another analysis. It used to take time. This is why we didn't show here. But those who were severely malnourished, the mortality rate was significantly higher among them.
And this is a bit out of the left field, if you like. You're the inventor of the bubble CPAP device. And is there a role for using that low-tech CPAP device to help manage shortness of breath that may be related to fluid overload or for any other cause in this patient population?
Yeah, very important question. Actually, you are quite right. When actually bubble CPAP was, it has been mainly used in our Dhaka Hospital of ICD for the last 7 years, mainly for the children with severe pneumonia and hypoxemia. However, many of our patients come with severe sepsis and septic shock, and many of them it used to be sourced from severe pneumonia and hypoxemia. And when we used to use bubble CPAP in those children, and we found very good results, and the survival rate is very high here. Overall survival rate around 95%, but those who have septic shock as well as shortness of breath and pneumonia combination, survival rate around 80% among them. Yeah.
Okay, wow, that's great. Listen, thank you very much, Dr. Chisti, and thank you so much for coming away from your very heavy workload. And I wish you and your patients very well. Thank you.
Thank you very much. It is my pleasure.
Thank you. Okay, so I'd like to thank you all for joining us here today, and in particular thank our sponsors who without their assistance we wouldn't be able to deliver on this really important Congress that is so accessible across the world. And I'd like to thank our organisers, the Global Sepsis Alliance, and in particular Marvin Zig and his team for putting this Congress and session together. And I hope you enjoy the rest of the Congress. Thank you very much.